Welcome back to the critical appraisal issue of EP Edge Journal Watch, Background and Breakthrough, where we bridge science to practice. I'm Dr. Niraj Sharma. Today we explore the AQUATIC Trial published in the New England Journal of Medicine 2025. It asks a deceptively simple question. For patients with atrial fibrillation and chronic coronary syndrome long after stenting, does adding aspirin to oral anticoagulation still help, or does it only harm? To answer that, we'll walk through 4 decades of progress, from warfarin to DOACs, from dual therapy to monotherapy, culminating in the AQUATIC Trial. Let's have a quick pathophysiologic background. Atrial fibrillation promotes atrial stasis, endothelial dysfunction, and a thrombin-dominant state, so-called Virchow triad, that drives clot formation and stroke. Coronary artery disease, by contrast, is platelet-driven, triggered by plaque rupture and local inflammation. When both coexist, therapy becomes a balancing act. One process demands anticoagulation, the other antiplatelet therapy. The shared foundation, inflammation, oxidative stress, and tissue factor activation explains why we've historically combined drugs and why bleeding so often followed. Our challenge has always been to find equilibrium, protecting both the brain and the coronaries without overwhelming hemostasis. And to appreciate how we reached that equilibrium, we have to go back to the early trials that first taught us what worked and what didn't. From warfarin to DOACs, let's start in the 1980s and 1990s, the warfarin era. A FASAC, Lancet, 1989, showed warfarin reduced stroke by about 60% versus aspirin or placebo. BAT, F, New England Journal, 1990, confirmed benefit in non-valvular AF. SPAF 1 and 2, Stroke 1991-94, refined stroke risk stratification. Cafe, Jack, 1991, and Active W, Lancet 2006, sealed the verdict. Oral anticoagulation outperforms dual antiplatelet therapy. But warfarin came at a cost: 2 to 3% per year major bleeding and roughly 1% intracranial hemorrhage. When coronary disease entered the scene, triple therapy, warfarin plus aspirin and clopidogrel, became routine, and bleeding skyrocketed to 10 to 15%. We needed a safer, simpler anticoagulant. That search opened the door to a revolution, the era of the DOAC. The DOAC revolution. Between 2009 and 2013, 4 New England Journal trials evaluating non-valvular atrial fibrillation and systemic embolism transformed the field. Relay tested dabigatran in 2009, non-inferior to warfarin with 70% fewer brain bleeds. Rocket AF 2011 brought rivaroxaban, similar efficacy, less intracranial hemorrhage. That same year, Aristotle showed apixaban reduced stroke, major bleeding, and mortality. And finally, Engage AF-TIMI 48 2013 confirmed class consistency with edoxaban. Together, they delivered predictable dosing, no INR checks, and half the brain bleeds of warfarin. By 2014, DOACs had replaced warfarin as first-line therapy. But for AF patients undergoing PCI, another question remained: could we safely drop aspirin? That question defined the next chapter, the era of AF-PCI trials, AF-PCI and the AFIRE prelude. Modern trials answered that question. Wovest, Lancet, 2013, warfarin plus clopidogrel without aspirin cut bleeding by nearly half, no increase in stent thrombosis. Pioneer AF-PCI, New England Journal, 2016, rivaroxaban dual therapy reduced bleeding by 40% versus triple therapy. Redual PCI, New England Journal, 2017, dabigatran dual therapy, 50% less bleeding. AUGUSTUS, New England Journal, 2019. Apixaban was safer than VKA, aspirin nearly double bleeding. Entrust AF-PCI, Lancet, 2019, edoxaban dual therapy non-inferior for efficacy and safer overall. By 2020, the message was clear: dual therapy is enough. Aspirin's role ends early. Then came AFIRE, the Japanese trial that set the stage for AQUATIC. AFIRE, New England Journal, 2019, tested rivaroxaban monotherapy versus rivaroxaban, plus an antiplatelet in AF with stable coronary artery disease. It was stopped early for excess mortality and bleeding in the combination arm. Monotherapy was non-inferior for ischemia and superior for safety. Limitations, however, remained. Japanese only, lower doses of rivaroxaban, open label, but the direction was set. After 1 year, DOAC alone may be enough. Before we sign off, let's take a step back and look at what the AQUATIC trial didn't tell us, because every study, even a landmark one, leaves some questions on the table. First, sample size. Only 872 patients were enrolled, far smaller than the massive DOAC trials that shaped our field. That means less power to explore important subgroups: renal impairment, complex PCI, or heavy atrial disease burden. Small numbers can exaggerate effects or hide nuance. Second, the trial was stopped early for harm. While that was the right ethical decision, early termination can inflate risk differences and leave long-term ischemic trends unknown. We may have seen a signal amplified by timing rather than true magnitude. Third, geography. AQUATIC was conducted almost entirely in France, a homogeneous European population. That limits generalizability to East Asian or South Asian cohorts, Africans where bleeding and thrombosis behave differently, and DOAC dosing strategies vary. Fourth, drug heterogeneity. Nearly 90% of patients took a DOAC, but multiple agents were allowed without randomization by type. Apixaban, rivaroxaban, dabigatran, edoxaban all behave a little differently. Without stratification, we can't tell if one drives the bleeding curve more than another. Fifth, anatomy and procedure complexity. Despite labeling this a high atherothrombotic risk cohort, only a fraction had truly complex PCI, multiple overlapping stents, bifurcation work, or long segment disease. That means for our patients with diffuse coronary disease or recurrent restenosis, we're still extrapolating. Sixth, event adjudication. Bleeding was defined by IST criteria, but minor and non-major events were underreported, and there was no centralized imaging core for confirming stroke or myocardial infarction. In a world where silent cerebral events are common in AF, that leaves room for uncertainty. Seventh, mechanistic insight. The study didn't include biomarkers, no D-dimer, no platelet reactivity, no CRP or endothelial markers. We don't know who bleeds because of biology versus who bleeds because of chance. Eighth, a small subset, about 10%, were on anticoagulation for reasons other than AF, venous thromboembolism, left ventricular thrombus, other indications, but outcomes weren't separated. That heterogeneity muddies the pure AF plus coronary disease signal we'd like to see. Ninth, adherence and dose verification. Therapy compliance was self-reported, not plasma validated. Even minor crossovers, stopping aspirin, missing DOAC doses, could bias results toward showing harm. And finally, duration. 2-year follow-up captures early safety, but not the full chronic risk of AF plus coronary disease, patients who live a decade or more. Whether event curves converge or whether some late ischemic penalty emerges, we simply don't know. So what do we take from all this? AQUATIC is confirmatory, but not conclusive. It strengthens the case for DOAC-only therapy in most stable AF plus coronary artery disease patients, but it also reminds us that simplification must remain individualized. The patient with 3 stents, chronic kidney disease, or diffuse diabetes may still need a bespoke approach. In other words, this trial refines the story, but it doesn't close the book. And that's exactly where thoughtful electrophysiologists and thoughtful clinicians should live, at the intersection of evidence and individualization. Thank you all for listening and joining me for this EP Edge Journal Watch podcast, Background and Breakthrough, the AQUATIC Trial. I'm Dr. Niraj Sharma. Take care and bye for now.